Hi, my name is Melvin Ocaña, and I'm going to talk about coronary angiography after cardiac arrest without ST segment elevation. Definition: coronary angiography is a procedure that uses contrast diode, usually contain iodine, and a X-ray pictures to detect blockage in the coronary arteries that are caused by plaque buildup.
Ischemic heart disease is a major cause of out-of-hospital cardiac arrest. In patients with cardiac arrest who do not have ST segment elevation on ECG, the role of immediate coronary angiography and percutaneous coronary intervention after successful resuscitation is unclear. In this multi-center randomized open-label trial, 552 patients who were successfully resuscitated from out-of-hospital cardiac arrest and who did not have ST segment elevation on ECG were randomized to an immediate invasive strategy with angiography and revascularization, if appropriate, performed within 2 hours, or to a delayed invasive strategy with angiography and revascularization, if appropriate, performed after neurologic recovery. 14 patients were excluded after refusing retrospective informed consent. The primary outcome was survival at 90 days. A key secondary outcome was 90-day survival with a cerebral performance category score of 1 or 2, indicating good cerebral performance or no more than moderate cognitive disability. There was no significant difference between the intervention groups in the primary outcome. There was also no significant difference in the key secondary outcome of 90-day survival with a cerebral performance category score of 1 or 2. The authors conclude that in patients successfully resuscitated from out-of-hospital cardiac arrest without signs of ST segment elevation myocardial infarction, an immediate invasive strategy does not improve survival at 90 days as compared with a delayed invasive strategy. Full trial results are available at nejm.org.
Application in medicine. Ischemic heart disease is a major cause of out-of-hospital cardiac arrest. The road of immediate coronary angiography and percutaneous coronary intervention. In the treatment of patients who have been successfully resuscitated after cardiac arrest in the absence of ST segment elevations myocardial infarctions remains uncertain.
The COAC trial is a pretty important trial for interventional cardiologists because oftentimes we get called from the emergency room or even out of the hospital for patients that have a cardiac arrest. Typically, most interventionalists have challenged themselves to try to take care of these patients because many times those patients can have a lot of benefit from what we do, but there are many patients that might not benefit as well because of the cause of their arrest and the fact that they may have an oxic brain injury. And so what the idea of this trial was to sort out was whether taking those patients to the cath lab and doing an angiogram was associated with different survival than if we sort of delayed the angiography, which is what often happens in these circumstances. Notably, they excluded patients with STEMI or VF or some clear reason to go to the cath lab. And what the trial showed is there's really no difference in outcomes with an earlier strategy versus a delayed strategy. Interestingly, people did have disease. They had a lot of multivessel disease, and 40% of patients got revascularized with the earlier strategy of revascularization. But delaying the revascularization didn't seem to be associated with any differential decrease or increase in mortality. And in some cases, the most sick patients crossed over and had angiography, but that wasn't really a lot of patients.
This is the first randomized trial that actually is testing the question, should you take this non-ST elevation cohort? The short answer is no. In fact, in this trial, there was no effect on 90-day survival. And so essentially, if you go to the cath lab to answer a clinical question, that might be reasonable, but certainly it's not going to affect survival. And so therefore, you probably shouldn't do it unless there's a very compelling reasons. And the compelling reasons could be cardiogenic shock or something else that would affect mortality. This trial was too small to address these sort of subgroups. But in general, I would say that this will simplify the matters for us because this comes up all the time in our practice. It's a fairly large cohort of patients. And it would appear, although the authors of the study couldn't address this really, that this is an electrical issue. because there was no culprit vessel in the majority of the cases. So that helps us a lot for the future.
I think the take home for interventionalists is that you can probably sleep a little bit more, or at least go back to sleep when they call you, as long as the patient doesn't make a clear indication for coming to the cath lab, like STEMI, VTVF, or perhaps even just progressive cardiogenic shock where they might need some other stabilization.
Pros and cons. Its main effectiveness is it serves to measure a narrow or obstruct coronary artery or also to know how the function of the heart chambers work. Cons involves a slight increase in risk when compared to other heart exams, and there is a risk of bleeding, infection, and pain at the intravenous or catheter insertion site.
Coronary ischemia is the most common cause for ventricular dysrhythmias. For patients with ventricular tachycardia or ventricular fibrillation without an apparent alternate cause, emergent coronary angiography should be considered in order to potentially open an occluded vessel. Patients with cardiac arrest following an ST elevation myocardial infarction should be taken emergently for percutaneous coronary intervention as soon as possible, just as those without arrest. Some patients will continue to remain unstable until their coronary occlusion is opened, so it may be necessary to continue to provide circulatory support. Reperfusion after cardiac arrest may cause a variety of EKG abnormalities, which may be confusing. However, even among patients without definitive evidence of ST elevation after cardiac arrest, more than 25% of them may benefit from a percutaneous coronary intervention. Regional and institutional practice patterns should help guide intervention, but it's important to maintain a high suspicion for an acute coronary lesion in all patients with an unexplained ventricular dysrhythmia.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free
Issued athlete in Ecuador. In this multicentral trial, we randomly assigned 552 patients who had cardiac arrest without signs of STEMI to undergo immediate coronary angiography or coronary angiography that was delayed until after neurologic recovery. All patients underwent a PCI if indicated. The primary endpoint was survival at 90 days.
A coronary angiography, or cardiac catheterization, is an X-ray examination of the vessels and chambers of the heart, often done to identify any narrowed or clogged coronary arteries that are preventing blood from reaching the heart muscle. The study can also be used to measure the size and function of the chambers of the heart and the function of the heart valves. When you arrive at the hospital, an intravenous line will be started. You will be placed on a heart monitor, and you may be given an oral or intravenous sedative to help you relax. Most coronary angiography procedures last between 1 and 2 hours. Before the procedure, you will be placed on a table equipped with a fluoroscope, an X-ray imaging device. During the procedure, the fluoroscope will move around your chest in all directions to record pictures of your heart and coronary arteries from multiple angles. Most cardiac catheterizations take place through the femoral artery in the groin, but can also be done through an artery in the arm. The doctor numbs the skin in your groin area and inserts a needle into your femoral artery. Once the needle is placed, a wire is passed through the needle and gently guided through the arterial system to the heart. The needle will be withdrawn and exchanged for a small flexible tube called a sheath that permits access to your femoral artery. Next, a soft, flexible catheter will be slipped over the wire through the sheath and threaded up to your heart. Your physician will watch the movement of the catheter on the fluoroscope. You may feel pressure as the wire and sheath are inserted, but you will not feel their movement inside your arteries. To evaluate the coronary arteries, your doctor will remove the guide wire, position the tip of the catheter just inside the arteries, one at a time, and inject a special dye. This dye allows the fluoroscope to take X-ray images called angiograms, of the artery's interior. Any blockages will be clearly identified as the arteries fill with dye. You may feel flushed or slightly nauseated when the dye is injected. After sufficient images of both coronary arteries and their tributaries have been recorded, the catheter will be removed through the groin. Pressure must be applied over the femoral artery to prevent bleeding. You will then be taken to the recovery room for 30 to 60 minutes of observation, after which you will be required to lie on your back for several hours with a pressure bandage in place over your groin. You may either be discharged home on the same day or after an overnight stay in the hospital.
Conclusion. Coronary angiography was not found to improve survival 90 days compared to delayed coronary angiography. Patients allocated to immediate coronary angiography reached their target temperature later as compared to delayed coronary angiography. There was no significant difference in myocardial injury between the two treatment groups.
എൻ്റെ പേര് സദറുദ്ദീൻ എന്നാണ്. ഞാനിവിടെ ബഹ്റൈനിലൊരു ഇൻഡസ്ട്രിയൽ ബേക്കറിയിൽ വർക്ക് ചെയ്യുന്നു. കഴിഞ്ഞ ഫെബ്രുവരി 19 എനിക്കൊരു ആഫ്റ്റർ ലഞ്ച് ബ്രേക്ക് ഞാൻ ജോലിയിലേക്ക് പോയപ്പോൾ ഒരു DC ഫീൽ ചെയ്തു. അങ്ങനെ ഞാൻ ബേക്കറിലെത്തി കുറച്ച് ബുദ്ധിമുട്ടായിട്ട് തോന്നി. അങ്ങനെ എൻ്റെ അസിസ്റ്റൻസ് വന്ന് ചോദിച്ചത് എന്താണ്, അപ്പോൾ പറഞ്ഞു എനിക്കൊരു നെഞ്ചുവേദന വരെ തോന്നുന്നു, കുറേ ബുദ്ധിമുട്ടായിരുന്നു. അപ്പോൾ അവർ ആംബുലൻസ് വിളിച്ച് സൽമാനിയ ഹോസ്പിറ്റലിൽ കൊണ്ടുപോയി. ഞാൻ അങ്ങനെ സൽമാനിയ ഹോസ്പിറ്റലിൽ പോകുന്ന വഴിക്ക് എനിക്ക് കുറച്ച് ശരിക്കും ബോധം ഇല്ലാത്ത മാതിരിയായി. അവിടെ ചെല്ലുമ്പോഴും ഇങ്ങനെ വിട്ട് ബോധം വന്ന് പോവുക. അങ്ങനെ അവിടെ ചെന്നപ്പോഴത്തേക്ക് അവർ പറഞ്ഞ്, പിന്നെ 2 ദിവസത്തേക്ക് എനിക്ക് ഓർമ്മയില്ല. 2 ദിവസം കഴിഞ്ഞിട്ട് ഞാൻ എഴുന്നേൽക്കുമ്പോൾ അവർ പറയുന്നത് വെച്ചാൽ എനിക്ക് കാർഡിയാക് അറസ്റ്റ് ഉണ്ടായി. പിന്നെ എന്നിട്ട് അവരെന്തോ മരുന്നൊക്കെ ചെയ്തു. 2 ദിവസം ഇതിൽ ICUവിൽ കിടന്നു. അത് കഴിഞ്ഞിട്ടാണ് എനിക്ക് ഓർമ്മ വരുന്നത്. ഏതായാലും 15 ദിവസം ഞാൻ സൽമാനിയ ഹോസ്പിറ്റലിൽ കിടന്നു. അവിടെ നിന്ന് ഡിസ്ചാർജ് ചെയ്യുമ്പോൾ എനിക്ക് ആൻജിയോ ചെയ്യണമെന്ന് പറഞ്ഞു. അങ്ങനെ അന്വേഷിച്ചപ്പോഴത്തേക്കും ഇവിടെ VHSൽ ആൻജിയോ ഇങ്ങനെ സ്റ്റാർട്ട് ചെയ്തിട്ടുള്ളത് നല്ല ഡോക്ടേഴ്സിൻ്റെ ഒക്കെ ഒരു ഇതാണെന്നൊക്കെ ഇങ്ങനെ അറിഞ്ഞു. അങ്ങനെ ഞാനിവിടെ ഡോക്ടർ അബ്ദുൽ അസീസ് ആസാദ് പിന്നെ ഡോക്ടർ പ്രശാന്ത് ഇവരെ ഞാൻ ബന്ധപ്പെടുകയും അവരോട് സംസാരിച്ചു. അവർ പെട്ടെന്ന് തന്നെ എന്നെ വെച്ച് താമസിപ്പിക്കാൻ പറ്റില്ല, വേഗം പോലും. അങ്ങനെ ഈ 11-ാം തീയതി, അതായത് ഏപ്രിൽ 11-ാം തീയതി ഇവിടെ വന്ന് അഡ്മിറ്റായി. അന്ന് തന്നെ അപ്പോൾ തന്നെ ഡോക്ടർ ആൻജിയോ ചെയ്തിട്ട് പറഞ്ഞു എനിക്ക് 3 ബ്ലോക്കുണ്ട്. 2 സ്ഥലത്ത് 90% വീതവും ഒരു സ്ഥലത്ത് 70% ബ്ലോക്കാണെന്ന് പറഞ്ഞു. അങ്ങനെ ഡോക്ടർ മോളും ഭാര്യയും ഉണ്ടായിരുന്നു. അവരോട് സംസാരിച്ച് പെട്ടെന്ന് തന്നെ തീരുമാനിച്ച് ഉടനെ തന്നെ അവർ 3 സ്റ്റെൻറ്റ് ഇട്ടു. ഏതായാലും 42 അത് കഴിഞ്ഞു. 42 മണിക്കൂർ ഇവർ ഒരു ഒബ്സർവേഷനിൽ വെക്കണമെന്ന് പറഞ്ഞു. അങ്ങനെ ഒബ്സർവേഷനിലിരുന്നു. എല്ലാം കഴിഞ്ഞിട്ട് ഇങ്ങനെ ഇരിക്കുകയാണ്. ഇന്ന് ഡിസ്ചാർജ് ആകുമെന്ന് പറയുന്നുണ്ട്. എനിക്ക് ഭയങ്കര റിലാക്സായിട്ട് തോന്നുന്നു. എല്ലാം നന്നായിരുന്നു. നല്ലൊരു ടീം വർക്കാണ്. അവരുടെ എല്ലാ സ്റ്റാഫും വളരെ എക്സലൻ്റ് ആയിട്ടുള്ള, എന്താ പറയുക, എത്ര അഭിനന്ദിച്ചാലും